Welcome back to PedsCrit. I'm Zach Hodges.
And I'm Alice Shinklin. And today we're talking about severe TBI management, which is such a core bread and butter topic. In this part 2, we're covering really the deep dive into hyperosmolar therapy and what those second-tier therapies look like.
Yes, and to do that, we have 2 expert guests. First is Dr. Kristen Smith. Dr. Smith completed her pediatric residency at Akron Children's Hospital, followed by a fellowship at Johns Hopkins. She currently is the PICU Medical Director and the Pediatric Critical Care Fellowship Program Director at the University of Michigan and C.S. Mott Children's Hospital.
Yes, and we are so grateful to her fellow, Carly Schmidt, for recruiting her for this episode. Dr. Carly Schmidt is a critical care fellow at the University of Michigan C.S. Mott's Children's Hospital. She got her medical degree from Case Western Reserve University and completed her pediatric residency at Brown University, where she also served as chief resident. Carly is interested in the intersection of PICU and the community via transport medicine, advocacy, and patient outcomes, and we can't wait to see what she does with her career.
Yes, we're so excited to share part 2 in this bread and butter pediatric ICU topic with you. Let's get right to the content.
So we have our 6-year-old who we've been taking care of. He has a severe traumatic brain injury with a subdural hematoma that's been evacuated now. We have the ICP monitor. We know we're living the good life with all of our monitors. Initially, his ICPs were between 8 to 12 in that immediate postoperative period. But about 8 hours after admission, your bedside nurse calls stating that the ICP is now in the low 30s, despite giving all of her available PRN sedation boluses. I think this is one of the big things we talk to the learners about and the people who are those first contacts. What is our strategy for this initial bedside assessment for this patient who, I'll call it out as, this is acute worsening intracranial hypertension? What's going through your head when you're thinking about this patient who's getting worse in front of you?
Yeah, so my first question is what changed, right? So were we suctioning? Did we change the bed? Did we put the head of bed down for a short period of time? Positioning is actually like the number one reason to just cause shenanigans in the ICU. And it's always at night because they always do the baths and the weights and all the things at night, right? So what was different? And this is a really refined, like for the fellows listening in, this is important because you don't want to walk in and say, well, what did you do? Right? Like you're stressed, you're nervous, you probably have a little bit of cognitive dissonance because you maybe don't know all the right answers because it's fellowship and life, right? So what's different? Like what changed? And let the nurses sort of explain, oh, yeah, actually we were suctioning. And so maybe you decide, well, I'm not riding it out because it's low 30s, but maybe we try another round of sedation. And so whatever was done, whatever was different, try to revert back to that scenario. And then take all that data, right? Kristen Smith asked for all these invasive things. What's my end-tidal CO2 doing, right? If you suctioned, is it now up? Is it now down? Has sedation needs gradually been increasing over the night and we're waking up and we're not ready to wake up. And so now I need to come up with a different sedation recipe for you. What are my NIRS doing in this moment? What's my CVP doing? Is my CVP also 20? Gosh, maybe I'm fluid overloaded. I don't have any venous drainage from the head. Am I wearing a C-collar? Is that in place, right? So head to toe, just sort of walk through just like you're entering the trauma bay for the first time. First question when you walk in the room, has anything changed and how can we revert back? And then the other things are head to toe, right? What are my pupils doing? Are my pupils still the same as they were, right? They might be big and reactive. They might be small and reactive. I hope they're not unequal. That's a different level of urgency. Make sure your C-collar is still fitting. Oh gosh, yeah, he came from the outside hospital with a malfitting one, or it wasn't the Miami J and we need them. Well, gosh, it's a little bit tight. Let's loosen. The simple things are like very easy, but gosh darn it, ICU nurses are amazing. And so they've often already done the easy things. So they're like, gosh, okay, so you got the C-collar, you check the pupils and they're fine. Your ventric is of course working. If you're draining CSF, it's working and it's draining. And you're like, man, those are all the easy low-hanging fruit here. What's my sodium level? Like when was my last blood gas? Is there a role for a 3% bolus here? You know, if my CVP is 14, maybe I don't want a volume load, but my sodium was only 145 and I've got room to rescue. I'm talking about this over many minutes, but we're talking about seconds of time, right? A lot of these things are PRN orders and we're saying, I'm just directing what you're giving. So in this scenario, I walk in, the ICP's 30, and I assume my ICU nurse has gone through all of those easy things, head of bed up, C-collar loose, sedation she's given. Then I'm going to probably give 5 per kilo of 3% pretty quickly through the IV. I may or may not ask what the sodium is because in this moment I'm in a crisis and I want to just give the bolus, and if my sodium's high, then I probably think about that differently after the fact. But if I don't have a sodium because we were Q6 and it's about time to gather that, I'm not going to wait for that sodium to come back to give the 3%. Make sure my ventric is still working. Maybe have the resident give neurosurge a call or have another cross-covering person just page neurosurge to the bedside, troubleshoot some things. I'm probably going to give another round of sedation. I love sedation. Here you go. Maybe bigger doses this time. What's my hemodynamic status, right? Is my patient hypotensive with a high ICP? Or are they hypertensive and have an ICP? Are they mad and their CPP is high because their blood pressure is driving their ICP to be high with more cerebral blood volume? Certainly need to get that down, and sedation generally will help with that. I'll also think about my patient's well sedated and an ICP of 30. Let's try some neuromuscular blockade. Are we febrile? Are we on the warmish side? Do I need to start that cooling blanket that I maybe forgot to because, gosh, we're all busy and we just missed it that one time? And so thinking about all of those like reversible things in that moment and getting those orders going. But the quick things you can do in that moment is sedate, paralyze, and 3% are probably the quickest options to rescue those things. Hyperventilation is another strategy in this moment, right? So if my end tidal is correlating with my blood gas, then I give my RT a very goal-directed. I want you to bag them down to about 5 lower than normal for this moment. I don't park them there generally. But like I've got seconds to minutes to save some brain from herniating if my ICP is truly 30 post-injury. And we have just a blessing of amazing RT staff in our unit. Some units aren't as well staffed just for a variety of reasons. So sometimes you're the fellow bagging. As long as you know what number you're bagging to, or you can let your nurse know what number to bag to, end tidal goal is like a map goal. But if you've got a big dead space fraction, you've got a big pulmonary contusion, or God forbid you've got a ventilator-associated pneumonia this early, you aspirated during the trauma, then you don't know your gradient. And so then you're just bagging to get as low as you can go until you know what that number is. The nice thing about continuous monitors, so if you have a Codman intraparenchymal monitor, that's a continuous tracing. So you can watch the effect of what you're doing. If you have a ventriculostomy and it's open to drain, you don't actually have a pressure monitor while you're draining. And so you have to take the risk of saying, well, I guess we're going to clamp it because we're not actually getting much CSF out, so I can see the effect of this mild hyperventilation. NIRS is super helpful when I'm using hyperventilation in the acute moment as well, because I know if my NIRS are dropping suddenly, if I get my CO2 to be too low, that I might have overshot. And if my ICP is sort of, even if it's mid-20s, I might let that CO2 rise a little bit higher to see what my NIRS will do. And those are all instantaneous. They'll give you feedback right there. If you had Google glasses on, the fellows and the attendings are going to be like, okay, I'm looking at that, and then I'm following that, and I'm doing this, and I'm doing that, and okay, and where are we now?
That's amazing. You did such a great job explaining the urgency. This is an emergency. This is a go to the bedside now.
Yes.
This is a comprehensive assessment, making multiple interventions in parallel, and it's collaborative. We need to get our neurosurgeons involved if our critical care resources are not fixing the problem, because this might be a time to pivot and get repeat imaging. This child might need to be taken back to the OR, and I think you encompass all of that in your answer. We talked a lot about hyperosmolar agents, whether it be hypertonic saline. It'd be remiss for us not to go ahead and jump in right now and talk about, what are your hyperosmolar sodium targets in patients like this, and what's your general strategy to get there?
I usually aim for like 145 to 155 to start. And the reason I don't start high is once you get there, you're stuck, right? You've got no rescue. And if your patient doesn't need you to get there just for the sake of saying, oh, TBI, GCS of 7, let's drive them to 155 tonight, then they don't need you to get there because, gosh, it takes a while to come back down, I'll be honest, especially when the kidneys are healthy. Or it takes a lot to get there because the kidneys are generally healthy in an otherwise healthy trauma victim. And so I try for 145 to 155 on that high end of normal to a little bit hypernatremic. We don't trend serum osms all that often unless we are worried about an evolving like DI, salt wasting, SIADH, some process like that. So I generally am using just 2 times the sodium because, in the serum osms calculation, those are going to be your 2 big players, as long as the glucose and BUN aren't horrendously high. So if I'm 145, I'm aiming for a serum osms of around 290, 300, something like that.
Yes, even though the total osmolarity is frequently tested in high-stakes exam.
Yeah, it sure is. Yes, please study that.
Yeah.
This is not the topic of this podcast.
That's right,
to
yes.
train you on that equation. But
That's right. There are fractions involved.
yeah.
It seems like hypertonic saline is the mainstay of what you're using, and mannitol maybe not as much. And I've been taught in the past that perhaps when there's disrupted blood-brain barrier that mannitol might be harmful. Do you mind filling in my thoughts there?
It sure can be. Alice, Zach, I'm sure Carly's never seen it used other than like the kidney transplant. Have you guys used mannitol in your clinical practice? Is anyone still using it?
And DKA,
Sure.
cerebral edema.
Oh,
Yeah.
we would give it as the second line, maybe if in this case you run through everything, it's not working, and now you're going from 30 to 35 for your ICP, the kid will get a dose of mannitol in hopes that you'll break the cycle. But yeah.
We didn't even use it much in my fellowship, so I think it's probably more the reliance of like, again, your training will mold you in ways you don't even realize till you're a faculty and you're like, oh, that's definitely a name
Like
my
that's
training
quirky.
site.
Yeah.
But 3% is just faster. It's faster to get. It's faster to draw up. It's hanging at the bedside. It's considered a high-risk medication, at least at our institution, and so you do got to grab the bag from the Pyxis, but as long as it's ordered for the patient, then you can just verbally instruct your nurse how much to give, where to give it. Mannitol is like glue. So my poor nurses who've been working their little booties off all day with this trauma patient, now I'm asking to like get the filter, draw up the glue. It's super hard. And then like to push it is also really hard. It crystallizes, not only in the patient, it can crystallize, but it also crystallizes in the vessel. You blow your IV. Gosh, you don't want to lose a lumen of your central line. And so it's like, I get that it may be equally effective or just not all that well studied in the moment, but there's enough risk factors just kind of piling up in my mind that it's like, yeah, falling out of favor. It's got a lower safety net profile, right? Serum osms have to be a little bit less in order to safely use it. So now I'm talking a lower serum sodium. It can cause renal injury in a patient who may already be at risk for renal injury. God forbid they have a contusion or a laceration of the kidney. I'm sure they have an acute evolving process. I bet I'm not perfusing their kidneys all that well because I'm preserving brain and heart at this point in time. And so all of those things, plus, when you have a patient who has a subdural hemorrhage, you cut open their brain to evacuate hemorrhage, you are going to cause the mannitol to go into the wrong place, and you can actually draw fluid into the brain as opposed to drawing it out. The only thing I love about mannitol is the rheologic effect, and so it supposedly makes the red blood cells a little bit less sticky, and so that's kind of a cool thing to do to the red blood cell, but that's temporary, and I think all of the other things are making it continue to fall under or even out of favor in my management.
That's a great answer to the question, and a bit of a practice variability in the sense that our institution I'm currently at, with hypertonic saline being high risk and the chance of it being swapped out for saline, has actually kept hypertonic in the pharmacy and mannitol available in the Pyxis. So if you really want to give a hyperosmolar therapy, immediately mannitol is the way to go locally. And Alice, I'm wondering about your situation.
Oh, 100%. If you are a DC PICU fellow and you're listening, you can get hypertonic easily in the PICU, but in the cardiac ICU, if you need to give it, you're like waiting at a tube station for at least 15 to 30 minutes. So I agree. And then mannitol, I believe, is in our code carts if you really need something fast. So
interesting, though, when they leave it in the code carts, it crystallizes. So then like you crack open the drug box and you get it and you're like, well, darn it, now I need another code box. Because like,
well, maybe I'm lying about that. I'm not.
No,
wrong.
I bet it is. It's in our code carts, but because it crystallizes, like its shelf life is not all that stable. But we just went through a similar process where it was like, gosh, hypernatremia. It could be so bad. And so Carly can speak to this. Now, every patient who has an acute neurologic condition as their primary reason for the ICU, they just have a 3% PRN. And so we have it in our Pyxis, but it's like nothing you can override. And so, and it's with all the silly override, right? You can't override Miralax in our Pyxis because it's electrolyte composition and whatever. And so you have to have a PRN for your patient, and then the door pops open and you can grab as many bags as you need. And so if you've got a grown, this is a 6-year-old patient, but if you have a 100-kilo grown patient, you can grab 2 or 3 bags and bring them to the bedside and you can bolus off of those. But yeah, it seems so low risk to me and high reward. But every time I go in my medical director hat, I go to a lot of pharmacy meetings about no. So they ask us, can the nurse come to the pharmacy window if the Pyxis is out? And it's like, no, I don't think people see ICP as a code. Like, it's a code. This is a brain code.
Yes.
But you push a code button and you walk in and you're just rescuing ICP, the anesthesia is going to come and be like, why are you calling a code here? But we should call a code. Like, this is a code.
It's the most important part of the patient,
and this is my
right?
epi. Like, this is epi in a brain code. So why can't I get it at the same? Epi is also a high-risk medication, but I can override it because it'll save someone's life. And just the field hasn't gotten around to saying, this is a code.
Yes.
Yeah.
Yeah, I was going to say that's actually my first or best experience with immediate QI in our PICU. Had a patient who had an acute worsening of this, and we couldn't get 3% quickly because of these reasons. And within weeks, we had a practice change in the unit because of, that event. And Kristen, speaking about her medical director hat, I think the role of using patient events to guide what we have accessible it's really interesting to think about in the ICU.
Oh, yeah.
I guess maybe rounding off hyperosmolar therapy, how do you typically use hypertonic saline infusions? Are those used really infrequently, and maybe which indications?
I would say we use them more than I'd like us to. For me, hyperosmolar therapy is a rescue, not a maintenance. And so if I've got a patient who's got coexisting traumatic brain injury and has developed cerebral salt wasting, I'll use a 3% infusion to keep them normal. But if I keep them at 165 with a hypertonic infusion, then how am I going to rescue them with 5 per kilo? That's not going to be an effective way. And so if I'm riding 145 just naturally, then let's let it be. Here's some normal saline. I maybe added some dextrose. Depends on what you're doing right now, buddy, with your age, right? 6-year-olds might need a little dextrose added in. But I'm not going to add a 3% infusion to get you to high. Again, assuming I have an ICP monitor, I have my NIRS, I have all the things that say, yeah, 145 is okay. Because then when he gets to 30, I can push the 3%. It's all about that initial bolus. It's not about keeping you at this steady state. It's the ebbs and the flows that give you the juice for the squeeze, in a sense.
Nice.
But Carly, you can attest, most of our patients that were driving sodium up, they sneak a 3% infusion in at some point. And it's like, oh, well, I wish that didn't happen.
Yeah, and then it's mostly just a diuretic at that point.
Yeah.
So we've discussed this patient. If your patient with a severe traumatic brain injury does have refractory intracranial hypertension despite your first-line therapies, right? Everything is perfect. You just can't get the ICP down. What next steps are you looking at?
I love barbiturates. Not personally, just for my patients. Pentobarbital, albeit has unfavorable side effect profile as a first line, which is why it's not in the first tier therapies, it directly shuts down the cerebral metabolic rate, like actually shuts down the cerebral metabolic rate in a way that like midazolam's just not going to do, in a way that general sedation, they're just not going to do that. And so if I've got such refractory events, I want to take away any work the patient's neurons are needing to do to heal. I'm going to treat seizures. So if I had seizures, I can now replace any other anti-seizure medicines with barbiturates, shut down the cerebral metabolic rate, and hopefully do that just for a couple of days and allow them to wake up from it. Now, the side effect profile, everyone gets a bad ileus. And so, gosh, am I not able to feed? Well, if I'm on full feeds and then I start the pentobarb, I'd be surprised, right? We're still working on doing better for enteral nutrition in our critical care patients, but maybe I tolerate the ileus. It certainly has an effect on the T cells, and so you tend to get more ventilator-associated events. But this patient's going to get at least a couple of days of ANSEF for that surgery they had. Our center tends to still be relying on some antimicrobial prophylaxis. If we have a ventriculostomy in, you're going to get some coverage for that, despite the evidence not being strong. I can probably treat a ventilator-associated pneumonia. If I'm lidocaine, if I'm not letting them cough, they're probably going to get it anyway. And so I'm not going to take a kid who didn't have any risk and now give them a ton of risk just by using pentobarbital. And then the hemodynamic consequences are treatable, right? If I'm on triple pressors when I'm thinking about starting pentobarb, I maybe get a little bit more nervous as that as my single agent, but luckily not the case especially in isolated head trauma. Is like you're probably a little bit more hypertensive. I can directly augment the side effect of pentobarbital with a vasoactive infusion.
Yes, all great answers. I guess there's variability in loading and maintenance pentobarbs. I'd like to know what your practice is.
I load, especially if I'm in an ICP crisis when I'm initiating. And so depending on the hemodynamics of the patient, somewhere between a 1 milligram per kilo to 5 milligram per kilo pentobarb load. And again, I've probably known the patient for some time, right? Are they real twitchy with their hemodynamics? Every little Medaz bolus, they're tanking their pressure. I'm probably going to err on the side of 1 per kilo, and I'll run it over 20 to 30 minutes as opposed to a 5 per kilo push. And then I start the infusion low at 0.5 because I'm only trying for ICP control. I'm not trying for burst suppression. This isn't the status epilepticus patient. I just want my ICP to be less than 20. I have an EEG on to make sure I haven't put them into electrocerebral silence and shut their brain down too quietly, but I'm happy to see some brain activity. If I'm on 0.5 milligrams per kilo per hour, plus that load, and my ICP is where I want it to be, that's another chef's kiss moment for me.
Excellent.
If you had burst suppression on your EEG, but your ICPs were still out of range, would you advance your pentobarb more?
Yeah, this is a conversation I have with the neurocritical care team all the time here. But yes, I would. That helps me talk to the family about just how severe this brain injury is and helps me counsel them a little bit on the road ahead. That road ahead's going to be a little bit longer. We're going to actually shut the brain down completely in a way that's not all that unhealthy when we extrapolate anti-seizure treatment for barbiturates. And so I'm going to tell the brain to do absolutely nothing for at least 24 to 48 hours. And then I need to wake it up safely. And that just tells me on the spectrum of severity, within severe traumatic brain injury, on the spectrum of severity within severe, you're on the upper end of severe traumatic brain injury. It also helps me tell my neurosurgeons, right? So if I'm at a place where we're also considering a decompressive hemicranie because I had a nice focal lesion that you could treat with something like that, then I say, look, I'm already burst suppressed. My ICPs are still mid to low 30s. Would you consider, as opposed to calling them urgent in the middle of the night saying, oh, we're electrocerebral silence and will you? It's more of a sort of academic discussion to say, I'm going to do this thing that also has a lot of risk here. Would you consider a surgical intervention a little bit earlier, knowing what we know about the trajectory of where we've been, where we are currently, and where we potentially are headed?
Oh, excellent.
So, curious your approach to using second-tier therapies that we have read about, but I don't know that I have a ton of experience with kind of advancing our hyperosmolar therapy beyond the sodium of 160. I don't know that I have pushed a patient to do that, but curious to know your approach and what patients you're using that in. And then pushing them further in their temperature goals to be even colder, so targeting that hypothermia. And then keeping them hyperventilated, I think, is another discussion that we have with our neurosurgeons a lot as well.
Yeah, so I'll start with hypothermia. I generally don't unless they were also a post-trauma arrest patient. And then I'll target a sort of moderate hypothermia, again, considering a coagulopathy as well. So that first 24 hours is really hard because if they're bleeding and they had a head bleed and cooling them might help neurologic recovery, but it might make their head bleed worse, that risk benefit is really hard. Outside of that first 24 hours, though, after trauma-induced coagulopathy is generally controlled, they're creating their own factors again, then I would consider a more moderate hypothermia if all else had failed. Hyperventilation I like as a rescue, but same story as hypernatremia, just letting you sit and park at a level if there's not been a perceived benefit. There's definite risk with prolonged hyperventilation, and I wouldn't do it without a NIRS in place. If I'm riding them 25 to 30, the parents know the risk, the surgeons know the risk. I don't feel great about the risk, but if we're waiting for someone to come, if we're waiting for, usually it's because you're waiting for something. You're waiting for something to happen so that you can get to the next therapy. I'll do a nice 6 to 12 hour period of let's see. But if my NIRS drop right away, then I go right back to normo. Again, first do no harm, right? Like that's our oath that we took. And I'm not going to cause harm when I've got no perceived benefit. I will say that there are patients where, mostly for cultural, religious, ethnic reasons, they just can't say to stop. And if you've got a severe TBI and I'm telling a family, I'll do everything I can to prevent this, then I will push the sodium just a little bit higher, the 160 to 170 for a 24-hour trial period, and then say, unfortunately, the writing is on the wall. And I've stretched medical expectations beyond what I would otherwise. And I'm so sorry, but it didn't help. And again, you've got the ICP monitor in to know whether that was helpful or not. So maybe that is the kid you bolus a couple of times. And to be honest, you'll need a 3% infusion to keep them up there. But that's mostly because they're not a surgical candidate. They've had yet another complication, God forbid they had an ischemic event on top of a hemorrhagic event. And now you're like weighing that clotting and bleeding and clotting and bleeding. And so it's usually as a last ditch effort. Similar in the sense, I don't call a patient after a code without needle decompressing both sides of the chest, right? I don't let a patient die of a neurologic injury without pushing the limits to the 160s or 170s, unless it's within the family's wishes to just stop.
Yes, all that sounds great and very reasonable and in line with our local practice. So, Kristen, we've had a great conversation thus far. These TBI patients are so incredibly complex, and they're meeting with emergency physicians, trauma physicians, neurosurgeons, intensivists. Maybe there's associated organ dysfunction. A nephrologist is involved, and communication. I find it's just so challenging. Sometimes our families say, he's in a medical-induced coma, and there are dozens and dozens of healthcare providers speaking with them every day, and there are many pitfalls. Prognostication early is a pitfall. I just wanted to open up and give you an opportunity to talk to us about communication strategies with the family. What do you see as some best practices here?
Yeah, I think in the first 24 hours, everyone is in shock, including the patient and their family. And so I speak very basic. I speak with my worries and my hopes. Some of the patients, my hope is we survive tonight. We are still alive tomorrow. And some of it's, I hope he's back on the football team next fall, right? And it all depends on the injury and the sort of preceding events and all of the story that goes in. But I lead with my hopes because I think when you lead with worries, the family shuts down and they're not able to hear that you're also hopeful. And that can break down that therapeutic alliance that you really are the coordinator. It also depends on the folks in your team, right? Are your neurosurgeons they're very this is bad? Are your neurologists very oh, everything's going to be perfect, right? You'll know your team or you'll get to know your team, especially as you're starting as a junior faculty, and what their prognostic language is. It's always helpful to be in there. It's not probably the greatest use of everyone's time, but go back to the patient, right? Think about your why and be in the room when the neurologist says those words so that you don't even have to add anything, but you heard the words they said about their hopes and worries as well. And then come back later and see what the family took away from that, right? So you've talked to a lot of people today. I want to introduce my team as really just the coordinator of this chaos because this is the worst situation you've probably ever been in. Not any family's been through this exact same scenario. And what are you thinking? What have you taken away from the neurologist? And then you say, well, I'm hoping, and you lead for your hopes for the night, but I'm really worried that we might not be able to reach those goals 6 months from now. But I'm willing to work hour after hour. We got a team of people that are here to take care of Johnny or whatever the patient's name is. But I'm worried tonight that the brain is going to continue to swell, that we're going to run out of space. And once you run out of space in that box, there's really nowhere to go. And, if you know from the neurosurgeon, not a decompressive candidate, you can already sort of weigh for them what the options are. And I do that every shift, ideally, right? If I'm there for the day shift because I'm on service, I do it again at night. And I say, I'm on call tonight. I'm still here tonight. Maybe I come by with the on-call fellow and, this is the plan for tonight. This is what we're hoping for tonight. This is what we're worried about tonight. And tomorrow is a different story, right? Today I'm actually worried about the blood pressure being too high. And yesterday I was worried about it being too low. Because every shift, your hopes and worries actually probably should change in the first 72 hours after a brain injury. I've found that when I start with worries, the family just sort of shuts down because they're so sick of hearing the bad news. They're so sick of it. They know that the injury is bad. By the time they reach to you and you're able to sit down with them, your procedures are done and you've stabilized, we're talking 6-8 hours into the worst night of their lives, the worst day of their lives. And so give them that grace of I'm not here to give you any more bad news. I'm here to lay on the table what bad news we all know. If they heard nothing the neurologist said, if they heard nothing the neurosurgeon said, then you know that no matter what you say right now, they're just in survival mode, their own personal survival mode. If they took it away and they're yep, and we're doing great, they're just one of those people that's just always hopeful, the eternal optimist. You can maybe guide your conversation a little bit differently for that. But I always introduce our team as the coordinator of that chaos so that they know no matter what, they can come to us. And I might not be the one cutting with the knife. I might not be the one deciding the surgery or not, but I'm the person who's doing all the other stuff, right? I will often do the mom thing where I talk to the other mom and I'm getting ready for Christmas and Santa and you're doing all the work and then Dad certainly gets all the credit too. And that's fine if Dad, the neurosurgeon, wants to take all the credit for the good outcome, because he was a big part of paying for the gifts, I guess. Dad paid for the gifts. But, I'm making the lunch, I'm packing the lunch, I'm doing the birthday, I ordered the birthday cake, I did all of the things. So if you need to come to me because you're feeling rough, or you need to cry, or you need to emote that like you lost your job because you're here, that's what the PICU team is also here for. Because if you don't take care of yourself now, this is going to be a really long road of recovery, right? Because we're talking weeks in the hospital, we're talking rehab. And if you can't drink water and eat food in the next 2 days, the rest of these weeks to months is going to be really hard for you. So,
oh, that's beautiful. And I also want to make a comment here, because setting the realistic expectation with the family is so important. But have you guys also had the experience, especially as fellows, as you get integrated into the field, where you're like kind of really pleasantly surprised about how some of the TBI patients that you've cared for have done? Shocked, These are patients where just because you're on pentobarb doesn't mean it's too late. And just because you're doing another decompressive cranie doesn't mean it's too, it's really, I don't know. I feel like they sometimes do really well.
I agree. We're really lucky to have our inpatient rehab at University of Michigan. And so getting to see those outcomes down the road is exactly like you're saying, where you see those kids and that's what keeps you going and keeps you coming back to these patients and taking care of them.
Oh, yeah. That's awesome.
We tell a lot of the sad stories, right? The patient deaths, and we share in those experiences. We hold some debriefs for our patient deaths, and our PM and our colleagues were part of one. And they're like, gosh, your jobs are really hard. Would you ever like to hear about the really amazing stories? And I was like, yes. Why didn't I think of asking you before? So now once a week, I get like a little listed update of like inpatient and discharge rehab stories that, I filter and I share when the stories are amazing. But yeah, I love when they come back for their their cranioplasty. Like if they needed a decompressive, then we get to see them because they're about to go home, right? They're about to leave the hospital. And so it's always so fun to be like, oh yeah, we're putting you back together, man.
Yeah.
It's amazing.
Dr. Carly Schmidt, Dr. Kristen Smith, thank you both so much for joining us today. What key points would you like to reinforce, or what would you like to add before we wrap things up?
I think my key takeaway from today is a little bit broad, but it's that personalized approach to these patients that I think Kristen has really created a nice theme for today. I think these guidelines are excellent, and it's nice to have that starting point for all of these parts. But being able to look at every monitor in the room and utilize your tools and make adjustments to that plan for that patient that's directly in front of you is really important, and is definitely going to shape the way I take care of these patients going forward.
First of all, this was so much fun. Thank you guys for having me.
Oh, yeah. Pleasure.
I'm welcome to come back if you want to have me. But just kidding.
Yeah, you're
but I think my takeaway, I said it very energetically, but increased ICP or intracranial hypertensive crisis is a code. We need as a healthcare system to treat it as such. I think a lot of that's culture change, right? We're probably not going to ever get to the button pushing moment. But when we do, right, like when you go into a CPR event in your own hospital, the fellow stands at a certain place in the room. The nurse already has 2 or 3 Confederates. And when Carly gets a call, it's like, my ICP's 30. It's one nurse in the room. The RT's probably not even there. And so she's got to call for a couple Confederates, and you got to call your RT to come to the bedside. And we just need a better shared awareness that like seconds count here. Just because we're not seeing active CPR in process, like we're trying to do brain CPR here. So let's make it happen like that, right? And we counsel you guys in fellowship, like control the room, keep it calm. But like sometimes you want to push the button yourself and be like, staff assist, everyone come because we need help. I need 3 more nurses to be pushing meds. I need all of these things. I'm hoping that's the future for us, is that brain codes are treated very similarly to cardiac and respiratory codes.
Yes. Well, thanks so much again. It was such a pleasure interviewing you both. We're very excited to share this message with our listeners. And thank you for listening to this episode of Peds Crit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as replacement for medical advice. The views expressed during this episode by hosts and our guests are their own and do not reflect the official position of their institutions. If you have any comments, suggestions, or feedback, you can email us at pedscriptpodcast@gmail.com or find us on Twitter at CritPeds and at PedsCrit on Instagram for real-time show updates. If you enjoyed the show, please subscribe, rate, and review on your favorite podcasting application and share with your colleagues. Also, if you'd like to support the making of the podcast, please see the description for Venmo information and how to become a Patreon. Any donation will be appreciated. Thank you again for listening, and goodbye.
You know, Zach, we've been making PedsCrit for a while at this point, would you
You're right.
say?
More than 3 years.
More than 3 years. And I'm not sure if we would say we noticed any gaps in our curriculum, right? We're just doing what we do. Would you agree with that statement?
We generally keep our head down and just make one topic after another. We probably could benefit from a bit more oversight.
Yeah. So that's why we're so grateful to the Michigan Fellows. This fall, we got my email beeped and it was the Michigan Fellows saying, "Hey, Allison, Zach, you should consider this an open invitation to cover TBI management." And that was awesome.
And we really appreciate it because, we'd like this resource to be for PICU fellows and attendings, and we'd like it to be created by PICU fellows and attendings. So we really appreciate Michigan fellows reaching out to us and contributing to this episode and helping coordinate. And it's our pleasure to feature them and publish this episode to our listeners.
Absolutely. And if you, like the Michigan Fellows, have noticed a big hole in our content, feel free to reach out to us anytime because we would love to get on it and cover it, maybe even with you.
That's right. Reach out to us, email, on Twitter, maybe X now, or see us at a conference. We're always happy to discuss PedsCrit and talk about next opportunities.